Good morning, good afternoon and good evening, and welcome to our second webinar in a series. The International Federation on Ageing has been around for a long time, over 4 decades, and we're formally connected with the World Health Organization and the United Nations Economic and Social Council. Now, our vision is a world of healthy older people whose rights are both protected and respected. And in this sense, the time that we are now living in really speaks to the importance of coming together, collaborating and partnering towards common approaches with common solutions. The IFA for nearly a decade now has been concerned and working in the field to improve the uptake rates of adult vaccination. And today we are going to have the pleasure of listening to experts from the United Kingdom and Australia. The reason that we have this series is because, as a soon-to-be Canadian, but also an Australian by origin, I've always been fascinated with what I see as inequities across this great nation. And I love being in Canada. But it really does disturb me that, from one province to the next, I may have access to different vaccines depending on who I am, what age I am, and which province I live in. And that should be a concern for all of us, because that speaks to the very equity of our nation. Canada has a strong universal healthcare system. And so when we are coming to the table to understand how we could support the great work of others in Canada, Immunise Canada, CanAge, CARP, and many, many more, what could we do to facilitate some strong discussions? A harmonised program in Canada has been on the agendas for a couple of decades. And so I'm really fascinated to understand, whether we in fact can work towards that. And there'll be many people on this call that says, no, we can't do that because it's provincial jurisdiction. We are in a time when we actually have to challenge everything that we know, to move not only through COVID, but to set new agendas for populations of all ages, including children and older people. And so this, discussion today, needs to be robust. It needs to be argumentative. We can agree to disagree, because we need to challenge the normative behaviour now. So in that context, I'd like to first of all introduce very briefly our 3 speakers who will make presentations, and then we will go and have a robust discussion, I'm hoping. So as Andra has said, and thank you Andra Stanku for being really the project lead on these important series, all questions and comments can go in the chat box. And we can speak to that as well as, call on you for questions. The first speaker is Dr. George Cassianos, Immunisation Lead, Royal College of General Practitioners in the United Kingdom. George has been the National Immunisation Lead for the Royal College of General Practitioners since 1996 and is a Fellow of the RCGP. He's also a member of the UK Public Health Advisory Panel on Healthcare Workers infected with blood-borne viruses. He's a founder, member, spokesman, fellow and president of the British Global and Travel Health Association. And before I introduce our next 2 speakers, may I just congratulate Dr. Cassianos, because just yesterday you were awarded the CBE in the United Kingdom. So congratulations, sir. I also asked you, what gets you up in the morning? What excites you? And you had, I think, about 38 years as a general practitioner, and you still were inspired to get up, do your exercise at 5:30 and be at the clinic. So thank you for being with us today. The next speaker, I believe, is Professor Holly Seal, Senior Lecturer, Public Health and Community Medicine, University of New South Wales, Australia. I've heard Holly speak before. Passionate, scientifically based, formidable, and a pleasure to have on this webinar today, because she actually questions what we do, how we do it, and how we can do it together. So it's a great pleasure to have you with us today, Holly. And might I say that just what I'm saying is just a 0.1% of these expansive bios. And the third speaker is Mr. Kim Sampson, Chief Executive Officer, Immunisation Coalition. Kim is not only the CEO and Company Secretary of the AIC, this was an inaugural role in 2008. He has spent more than 35 years as an administrator in medicine and science, public and private health and community services. He's also the Executive Director of the Asia Pacific Alliance for the Control of Influenza and the President of the Australia-Vietnam Friendship Society. It's critical that Kim is with us today because Kim really represents, a body of civil society that must be legitimately at the table when we come to talk and deliberate around not only harmonisation programs, but really how to actually impact the rates of vaccination across the life course. So please welcome all of our speakers, but most particularly newly awarded CBE, Dr. Cassianos. Thank you, sir.
So good afternoon, ladies and gentlemen, if you're in Canada. It really gives me great pleasure to be with you today to talk about the immunization program in the UK and really give you a very brief introduction to it, because normally this is a subject for about 45 minutes, but I have 15 minutes of your time and I want to use it really very wisely. First of all, the burden of influenza is huge, and in the UK, we get about 8 to 11,000 deaths every year from influenza. If you look at 2019, we had just under 8,000 deaths, of which really the vast majority are in the elderly, 65 and over. But we also had children dying of influenza as well as young adults. And the worst year, of course, was 2017-18, when we had just over 22,000 deaths from influenza, of which the vast majority were in the 65 and over. It is my view that to have a successful influenza campaign, vaccination campaign, you need to have three foundations: the government, the patients, and primary care. And these three need to work together, because if one of them is not engaging, then the campaign really cannot function well. And it is very important to get all three, patients, primary care, and government, working together. Now, if we look at the government, we need to have a government that is committed in preventing influenza by vaccination, one that really works with its stakeholders, is guided by experts, and really provides the flu vaccine entirely free to the risk population, has got a very good public health department that is very, very active, produces posters, leaflets, letters to patients, defines for us very clearly which groups are at risk that are eligible for vaccination on the national health system, and also a government that supports a national IT system, therefore is able to extract vaccination rates and other information and surveillance any day, any time, which then they publish. And we would like to have anything like this weekly, so that we actually know where we are, and a government that incentivizes vaccinators. Now, in the UK, the decisions are taken not by the ministers, not by the government, but by a committee of experts, the JCVI, the Joint Committee on Vaccinations and Immunization, to which the Public Health England feeds with vaccine coverage, clinical trials, monitoring of the side effects and the efficacy of the vaccine, also surveillance, serological and disease surveillance, mathematical modeling, and so on. And the JCVI takes decisions. If the JCVI recommends to the government something, then the government has to do it. For example, in 2012, the JCVI recommended to the government that we vaccinate healthy children. We're talking about 9 million healthy children at a cost of 100 million pounds. The government had to do it. The ministers had no other option but to do it. But if the JCVI advises the government, then the government may or may not take that advice. Now, the government updates the Green Book, which is electronic, according to advice it gets from the JCVI, and it publishes for me the e-letter, which is actually the flu plan, which arrives usually in March. This year, it was a little bit later in May, and it gives me all the information I need to start my campaign in September. The government also finances all the hard and software on my desk, in which case is able to extract the information it needs, vaccination rate and so on, which it cascades down to us, not only publishes for the whole country to know, but it cascades down to us to practices, in which case each practice tries to do better than what they were doing before. The government also publishes the vaccine update, and this is one of the latest editions, which is wholly dedicated to influenza, but also the annual contract for the GPs and information about for patients. And you can see here on the next slide, I'm having a little bit of difficulty advancing them, but I hope it will advance to the next slide, please. Here, a plethora of leaflets, and it can be for any age, any situation, whether it's healthcare professionals like here, or children, or any disabilities, or pregnancy and so on. We have leaflets, posters for everything and available in many languages. For example, these here you see are available in 18 languages. Why? Because we want healthy aging, which actually starts from childhood. So we look after the children from conception to really old age. Now, next slide, please. And you can see here, any disability is also covered for me, and I have got really leaflets and posters to give to my patients. There are letters which are published by the government for the parents, for the children, 2- and 3-year-olds, the consent form for the parents to actually sign. Any patients in the groups at risk, there is always a letter for me to put in the computer populates and sends out, so it's not really much of work for me to do on that. Next slide, please. And you can see here that if there is a problem in a care home, immediately the government will advise me how to actually manage cases like that, will send me a poster for the visitors and so on. Next slide, please. And also, it gives us also slides ready to go and do a lecture for healthcare professionals, for patients. We have got e-learning courses there that we can actually use. Next slide, please. And the vaccines we use in the UK are really vaccines that are specific for each, specific ages. And we have got the children actually having the intranasal vaccine, the LAIV, and then we have got the younger ages up to 64 having egg-derived or cell-based vaccine, and the over 65, the adjuvanted trivalent. Next slide, please. Here you actually see that the trivalent egg-derived, we do not use at all. We're not allowed to use it. The high-dose trivalent is available in the UK, is licensed for 65 and over, but is not reimbursed by the NHS, so I cannot really use it, because if I buy it, I have to pay for it, and I don't get any reimbursement. So what remains here, next slide, please. It's the egg-derived vaccine and the cell-based vaccine, which are for the ages under 65. First, you have to use the cell-based vaccine, but the egg-derived is an alternative to the QIVC. And for the 65 and over, we have got the adjuvant trivalent. But if that was not available, then you can use the cell-based quadrivalent. That's how actually we use specific vaccines for specific ages. There are lots of posters that we can actually request entirely free from the government to use. There is a website where you can find all the information about the annual flu program of the government, which is actually very, very helpful to actually have. Every Thursday, the Public Health England publishes a bulletin where they give us information. You can actually see here the 2019, how the influenza-like illness visits to GPs were and compare with the previous year. In the same bulletin, you find information about hospitalization, about what put people in hospitals, what the information about the intensive care unit, and what strains actually put people in ICU. You'll find the results of the respiratory swabs we take GPs and send to Colindale for analysis there. You see other respiratory viruses, what is happening with those. Next slide, please. And of course, excess deaths, which this year, of course, were augmented by SARS-CoV-2. You find also the weekly vaccination rate of the whole country, of whole England, and you can actually follow that there, apart from the fact that you have got it for your own practice. So primary care needs to have GPs, nurses, pharmacists, all committed to vaccination, very well informed, who are vaccinated themselves, as an example, very well organized staff. They provide lots of information to patients in their clinics, on their websites, in the local media. They provide convenient times and opportunities for vaccinations to patients, because this is very, very important for patients. And of course, we audit and re-audit and we recall patients. The primary care that is incentivized, and also primary care that opens access to vaccination, for patients for vaccination, and that is by involving the pharmacists vaccinating anybody age 18 and over who is eligible for vaccination on the NHS, and of course school services that will vaccinate children at school, because there you achieve much higher vaccination rates. The Royal College of GPs has the Research and Surveillance Centre, which it serves about 500 practices in England, over 4 million patients, and it gives information which Public Health England also uses. And if I can show you here, in the black is the 5-year average, in red is the all ages, but what I would like you to look at is the 15 to 64-year-olds. Any time of the year you look at is actually higher than all the other ages. Why? Because the 15 to 64-year-olds, we only vaccinate those in the groups at risk. But what you see here, it's actually due to COVID, because it's influenza-like illness visits to GPs. And here you see paradoxically that the children under 15 years old, the blue line was much higher than any other line. Why? Because we got our LAIV late, mid-November. Once we started vaccinating, you can see that the line for the children goes right down. This is the power of vaccination. We can reduce circulation of influenza in children by actually vaccinating healthy children. Here are the groups at risk that we vaccinate: children 2 to 11, anybody 6 months to 64 in the groups at risk, which you can see there, pregnant women, anybody in long-stay residential homes, health and social care staff, the carers, and also any household contacts of people who have been on the NHS shielded list because of COVID, we vaccinate them. If supplies of flu vaccine allow, we will also vaccinate healthy 50 to 64-year-olds. Now, who vaccinates in the UK? Primary care does, the GPs, the nurses, the healthcare assistants. The pharmacists vaccinate 18 and over. The school services vaccinate children at school. The hospitals vaccinate pregnant women in antenatal clinic. And from this year, they also can vaccinate in and out patients that are in the groups at risk eligible for the NHS vaccine. The pediatricians are based mainly in hospitals. We also have community pediatricians, but they're not involved in vaccinating children, infants, anybody. They only give advice. Now, this is actually our clinic, and we have a lead in the next slide, please, because it's not advancing. Can I have the next slide, please? Yes, we have a lead, we're a member of staff and a doctor that actually lead in the campaign. Next, please. There is a team that organizes and oversees the campaign. We put a lot of information out. We ensure that we have got enough vaccine, but we also photograph ourselves having the vaccine, and we put it out for patients to actually see on our website. I cannot advance it. Yes, and the next slide, please. And here you see all the doctors and nurses being vaccinated. And when I'm consulting with patients, there is this photograph right behind me, and the patient looks at that and reads, I had my flu vaccine, have you? Because this is the strongest message I can actually give to my patients for getting vaccinated, and opportunistically, we do a lot of vaccinations. Now, GPs received a fee of just over £10 for all the patients that are in the groups at risk from the government. In addition, we have got the system of QOF, Quality and Outcomes Framework. If you take coronary heart disease, if I vaccinate 55% of my patients with coronary heart disease, for QOF, I get nothing, no income. If I vaccinate 56%, I get 1 point. And as I move to 96%, that's where I get all the points, 14 points. The same is for stroke, COPD, diabetes. And each point is £194.83. So you can see there is an income there to be had if you vaccinate your high-risk patients. GPs buy the vaccines from the manufacturers, and the government pays us the list price. But of course, we usually get a discount from the manufacturer, which is another kind of income for the GP. The pharmacy is very similar to the GP, but they only vaccinate age 18 and over, and they must inform the GP of the patient that they have vaccinated the patient the same day or by the end of the next working day that they have done so. That's their contract. Why? Because then I put it on my computer, and the government is able to extract the information. Now, patients, very important, they need to know that they are in the clinical groups at risk. They are good patients that respond to invitations. They come and get vaccinated. They become ambassadors for vaccination among their friends, about media, anybody they actually meet. Parents that really allow their children to get vaccinated. And of course, we have patients associations, which are very, very helpful when we actually do any mass vaccination campaign. And here they are, all happy and really participating in the practice. Now, what have we achieved vaccination rate? 65 and over nationally in England, 72.4%, 6 months to 64 in the groups at risk, about 45%, pregnant women, about 44%, and healthcare workers, hospitals, all these places, 74% last season were actually vaccinated. Now, can practices do better? Well, here is my practice. And in fact, from the previous season to last season, we took over another failing practice. So we should have done worse. And the total number of patients was 23,000. But you can see that the 65 and over, 87% were vaccinated. 6 months to 64, 67% were vaccinated. Pregnant women, over half were vaccinated, but those in the groups at risk, 70%, and healthcare workers, our staff and ourselves, 76%. Now, what about those very high-risk patients, coronary heart disease, COPD, diabetes, stroke? Just under 100% were vaccinated. You see 1,042 diabetic patients in my practice, 97% were vaccinated. Children, GPs vaccinate the 2 to 3 year olds, about 44%. In my practice, for both ages was 65%. And the school services vaccinate at school, and they achieve an average of 60%. Now, Mary Ramsey is the director of immunization here in the UK, and I wrote a blog for GP practices, 10 top tips how to achieve high vaccination rate. And we analyze in the blog for each of these what you can actually do to increase your vaccination rate. And finally, as we come to the end, I wanted to show you what happens when you vaccinate healthy children. Now, we started in 2013, and we had, in the first 2 years, the pilots, whereby we had areas where children were vaccinated in the primary school, age 4 to 10, to 9, 10, and areas where they were not vaccinated. And when you compare the two, what you find, and these are the p-values here, there is a relative risk reduction of visits to GPs with influenza-like illness by children who, in the areas where children were vaccinated, down by 94%, down by 74% vaccines to emergency department with respiratory symptoms, down by 93% admissions of children in the area where healthy children were vaccinated to hospital because of influenza. So children benefit tremendously. Also, everybody age 18 and over, the elderly, the young people, everybody, there was a 59% reduction in visits to GP with influenza-like illness in the area where we're vaccinating healthy children. And that is actually, I think, speaks for itself. So in conclusion, ladies and gentlemen, decisions on disease prevention by vaccination really need to be taken by the experts, not the politicians. The government needs to be very committed to protecting the population by vaccination. There has to be a national IT system where all systems are the same, then they talk to each other and the government can actually extract the information. We need to have clearly defined list of groups that we're going to actually vaccinate. The vaccine must be entirely free. And really, as professionals, we need to be committed to vaccination. There has been a great impact in vaccinating healthy children. And in the UK, we operate specific vaccines for specific ages. And I'll leave you with the thoughts of Louis Pasteur, who said that when meditating over a disease, I never think of finding a remedy for it, but instead a means of preventing it. Thank you very much for your attention.
Thank you very much, Dr. Cassianos. You know, what a brilliant way to start off this virtual meeting this afternoon. There are so many questions that I have for you, but perhaps if I will just ask one question before we move on to Professor Holly Seal, and that is, you know, the value of culture, right? Now, it's quite clear that as a professional, you are absolutely committed to vaccination, you know, as a preventive, you know, one of the most effective public health interventions of our time. To what degree, you know, in your community, do you think, you know, the culture has actually helped maintain and improve those vaccination rates?
Well, there are, first of all, we need to see what drives vaccination rates. And I have to be really honest here. The fact that GPs and pharmacists get a fee is something. And there are more to earn if you actually do even better work. Then there is a competition between GPs and pharmacists. Who is going to get the NHS patient first? So my practice, as soon as the vaccines arrive, bang, we actually start. And on that first Saturday, we open the doors and people come in. In one Saturday, we vaccinate 800 patients. In fact, by now, we have vaccinated as many patients we vaccinated altogether last year until March, over 4,000 patients. And we are still going because more people are coming forward for vaccination. And we still have the vaccines to actually do that. But at the same time, patients demand their vaccine. They are ringing, where is my vaccine? You know, and if you don't have the vaccine there, they get very, very upset and they speak to the media that the doctors have run out of vaccine or the pharmacists have run out of vaccine. So what we have here is very committed GPs and pharmacists and very committed patients. Our government, I will give them full marks. They're very committed and they take the advice of the JCVI. Put the three together and you have got a good vaccination campaign.
All right, so I think we need some more disruptive seniors in Canada. So we'll now move on to Professor Holly Seal, Senior Lecturer, Public Health and Community Medicine, University of Western Australia. Holly is, as I said, a Senior Lecturer at the University of New South Wales. Her original qualifications were in biomedical science, and then she transitioned into public health by taking a PhD at the National Centre for Immunisation Research and Surveillance. So, Holly, I hand the floor over to you. Are you with us, Holly? So Holly was having some difficulty with her internet earlier on. So Andra, can you work out what's happening?
No, hello, I should be here now. Jane, can you hear me?
Yes, I can, Holly.
Lovely. Okay.
Off you go.
Okay, I can't do my slides either, so I'll have to work in tandem here. So thank you everybody for the opportunity to present this morning. I am coming to you live from my bedroom, as you can probably see my background. Not my normal spot for doing a presentation, but the wolves, or aka my two children, are at the door. So if you keep hearing some thuds in the background, it's because they're trying to break down the door and join the teleconference, which they like to do. So if we could go to the next slide, please. Before I begin, I'd just like to declare my conflicts of interest. I have received funding from a range of vaccine companies who I'd like to acknowledge for investigator-driven research. I've received education grants, travel costs to attend and present at scientific meetings. Thank you. I'd also like to acknowledge the traditional owners of the land that I meet on, and this is a normal custom for meetings that are held in Australia or on Australian soil. So I live in an area in Sydney called around La Perouse, which is on the Sydney coastline. So I'd like to acknowledge the Gadigal and Bidjigal peoples that traditionally occupy this lovely part of Sydney if you get to come down here at any point. Thank you. Very much kind of some of the sentiments that I'm going to cover over the next 15 minutes echo what George has started with and very nicely, hopefully, complement. But I'm also going to take somewhat of a step away from some of the sentiments put forward. And as Jane kind of alluded to earlier in the piece, that, you know, this is a time for needing also to challenge some of the status quo around our thinking of how we deliver vaccination. And to do that, firstly, I just want to kind of set the background about why I think we need some challenging, we need to challenge. So here in Australia, just like most other settings, you know, we do have a federally funded vaccine program for flu, and really, you know, that encompasses most of the, you know, the normal target groups, those who are older adults over the age of 65 years, of course, those with chronic health conditions, our pregnant women, and also our children. Now, it's interesting with each of those different campaigns is that they have emerged in different ways. And so for the children with the healthy children, the children with specific health conditions, and also really the pregnant women, most of those campaigns have actually emerged from state-based promotion and funding. And so especially, you know, for healthy children, we had a very strong push in Western Australia and a campaign for many years to promote flu vaccine to healthy children. Over time, that kind of then, you know, spread to the other states. And in 2018, we then saw that campaign go federally. So same happened in pregnant women. We saw kind of the emergence of that campaign in New South Wales, and then it trickled through to cover all of the states. So it's interesting to see kind of how these different platforms start. But for the most part now, and our traditional programs, you know, for those aged 65 years and over, they've really been in place since the late 90s, and, you know, and then kind of expanded in early 2000s to encompass people with the chronic health conditions. Next slide, please. But just like Canada, we are made up of a range of different states and territories which do have a handle on their immunisation programs and how they are run, how the materials are developed and distributed. And, you know, for some things we do work together, but other things we do work separately. And there are definitely great program examples that we can see have been running really well in some settings, which just haven't translated across to the other states and territories. And it often means here then that when we actually look at vaccine coverage, that we can see that there are discrepancies across the groups, across the different states and territories. And so kind of looking nationally, we know currently that our flu coverage for people aged 65 years and over is really good, you know, and it has been for many years. You know, we get uptake, you know, well into the 70s and in 80s in some settings. Just kind of departing somewhat away from flu, just for people who may be interested. We've also, of course, got a national zoster program in place for adults aged 70 years, between 70 and 80 years. And that program is still relatively new, I suppose. It's only been in play for now 3 or 4 years. Coverage for that sits around the 30% mark. The other program, of course, that we've had in play is our pneumococcal vaccine. That has had changes of late in terms of who is targeted for that. But estimates kind of at a national level put the coverage around 50 to 70% for that particular vaccine. So that's national figures. And why I wanted to kind of be the challenging point in this presentation is that when you actually drill down into those figures, there are definitely deficits in our vaccine coverage, as I said before, across geographical areas, but also deficits in terms of certain populations that we are just not reaching when it comes to our vaccine program. Next slide, please. And these kind of groups can be looked at in 2 different frames. Firstly, one of the key groups that I think we could be doing a lot better with is targeting adults with chronic health conditions. They are captured by our national immunisation program. There are a range of different health conditions, which I'm not going to go through now, but which are available on our immunisation handbook website, who are allowed and targeted for free vaccination, but we're not capturing them. For those aged under the 65 years, we are lucky to get about 50% vaccinated. And even in our older age groups that have, you know, a double whammy of risk category, both being aged over 65 years and having a chronic health condition, we're not even capturing all of those groups. But beyond that, also what we're not doing very well at the moment is ensuring equity in our vaccine delivery. And so that we know that amongst our culturally and linguistically diverse populations, that our vaccine coverage is also suboptimal. And that goes for groups under the age of 65, but also for groups over the age of 65. And this is particularly for those who have immigrated to Australia from a non-English speaking country. Next slide, please. And so the next couple of slides really just kind of show that data graphically. So this is data just for New South Wales, the state that I'm located in, looking at the variations by gender, but also by country of origin, or whether or not you came from an English-speaking country. So you can see that clear dip in flu vaccine coverage for those populations. Next slide, please. What we also need to be cognizant of is in Australia, as in Canada, we have a lot of rural and remote settings. So when we look at vaccine coverage again, that we see that there isn't equity in terms of our delivery by remoteness. And so those people who are living in kind of outer regional and remote areas of Australia really are not getting the same level of vaccine coverage that our people in major cities, of course, are getting captured by. Next slide, please. But I don't want to be all doom and gloom, because we have actually had a win of late with one of our population groups. And this population group is common between Australia, of course, into Canada, into the US. And what I'm talking about, of course, here is our Indigenous population. So people who identify as Aboriginal and Torres Strait Islanders. there has been a huge push to try and improve their vaccine coverage in the last couple of years. And we have seen gains to the point that in some settings, we are actually now vaccinating more of our Indigenous populations than non-Indigenous. And that's a real win, and congratulations there. And this is where I want to take my story, because I think when we're looking at trying to improve adult vaccination, we need to somewhat think beyond the traditional norm. So next slide, please. But I do want to echo what George has been saying in terms of the fact that primary care is our primary delivery of vaccination in Australia. You know, I think the average, you know, it's 90-ish +% of our vaccines are delivered in the primary care setting. Our GPs and our practice nurse are strong advocates for vaccination. You know, the bulk of the responsibilities for communicating and advocating, you know, really fall on their shoulders, and they do a really great job. But, and I'm sorry to add a but here, from those slides that I just showed before, we know that not everybody is coming into a primary care setting. And so it's not capturing all of the groups that we need to capture. Next slide, please. So kind of drawing on the thought of one size cannot fit all, and also trying to kind of push back on the notion that, you know, what works in childhood or adolescent immunization can be transferred across to the adult setting. I think we have too much of that rhetoric, and I really want to start pushing back on that thinking, that I think we need to start looking into some other patterns of vaccine delivery. And this really echoes kind of looking beyond primary care. How can we work with our local councils? How do we work with our pharmacy in a stronger way? And in Australia at the moment, pharmacy-based vaccination is very different across all states and territories in terms of what vaccines are delivered, what age groups are allowed, you know, and how much push there is in pharmacy. In terms of hospitals, again, our programs focus mainly on pregnant women and children, but we are missing other key groups here. And also looking at how we draw on strengths in our Aboriginal health services to ensure vaccine delivery. Next slide, please. And this is the kind of the first quick case study I just want to draw on, that, you know, in terms of that success story, it has happened because we have looked to deliver, to tailored delivery programs that are trusted and are, you know, have the reach and networks into the communities that we are trying to target. And so here in New South Wales, we established the Aboriginal Immunisation Healthcare Worker program back in 2012, and it's delivered via our kind of public health unit, so down to very local council areas. The remit of this group really was to focus on improving and reducing the gap in childhood immunisation. But interestingly, one of their KPIs is actually focused on adult vaccination and looking at how they can strategically communicate and advocate for adult vaccination in their local districts. Next slide, please. And these are kind of some of the key elements that they are responsible for, or some of the activities that they take on. And really it is working with local communities, with local stakeholders, and, you know, and trying to tailor programs, whether they be communication, whether they be delivery modes in this setting. Next slide, please. And they go very local. This is actually for my local area that I live, the lady that's responsible for driving forward the Aboriginal immunisation program. And so, you know, I know her name, I know who she is, you know, and I think that is such a key thing that we may miss with some communities. Next slide, please. And just like George alluded to before, you know, we have done a lot of work in ensuring that the language and the promotion materials is appropriate for these communities. And you can see the word there that kind of resonates across all of our Indigenous materials is the word mob. And that's a really key kind of touch point for these communities. I've got the timer on me now. I can see it, so I better keep going. Next slide, please. But, you know, again, that community approach, that tailored approach, again, won't meet everybody's needs. And so this is kind of where I become quite a little bit controversial maybe, that I think we need to start looking at another system to try and improve vaccine coverage for other groups. And here I want to focus on adults with chronic health conditions. And if I had more time, I would have loved to have spoken more about adults with adults who are culturally and linguistically diverse populations, because I do a lot of work in that area. And so happy to take that offline at any time to talk about how we can improve that. But, you know, adults with chronic health conditions, we're not getting to them. We are not getting to them in primary care because some of the emerging evidence is suggesting that these groups actually want to hear the messages about immunisation from their specialists. So those who are treating their chronic health condition, administrating the medicines and so forth. And so what's been suggested is that hospitals actually may be the next point of where we should be focusing on in terms of adult vaccination. And someone's actually written out and suggested that hospitals are where the money is when it comes to adult vaccination. But here in Australia, and it sounds like in the UK, we have very little adult vaccination occurring in the hospital settings. In comparison, we have a lot of paediatric hospital vaccination. So we have in most of our major paediatric hospitals in Australia, and there's about 4 of them, I think, 4 or 5. We have these great drop-in clinics that are open to patients, either inpatients or outpatients, and their family members. And these clinics provide catch-up programs. They provide distraction techniques. They provide telehealth opportunities. They work with children who have disabilities and other chronic health conditions to deliver their vaccine programs beyond flu, of course. But they do also deliver a flu vaccine drop-in program every year. Next slide, please. And this is the data that's come out of one of our paediatric settings. So it's the Royal Children's Hospital in Melbourne. And my hat goes off to the great group down there that does some work in trying to capture those kind of almost hard to reach children who come through the hospital. And you can see that, look, you know, the numbers aren't huge, but the key message here is that these children may have slipped through the gaps if they hadn't have encountered an hospital-based vaccine program. And what we know in the childhood space and also in the adult space, that if you are actually being actively treated in a hospital setting, you may not necessarily go back and engage with primary care during that hospital treatment period. And that is something we don't have enough conversation about. Next slide, please. Internationally, there is a lot of rich literature that shows that if we look to introduce an adult program through a hospital setting, that it can have a success. And this is a great study by Rimple et al. That showed evidence of an emergency-based program that was run that improved both flu and pneumococcal vaccine coverage. And you know, look at the numbers, up to 80% of the people that they were targeting got vaccinated. So it's been shown to be cost effective, and it's shown to be actually impactful in getting numbers up. Next slide, please. So can we adopt this model? In the last 5 seconds, we just recently did some work based on using funding from Seqirus, who I'd like to acknowledge for their assistance in this. That was actually looking at whether or not adults in Australia would be willing to accept a vaccine in Australia. This is unpublished data, so it's hot off the press. And we actually found that 3 out of 4 adults would be willing to receive a vaccine. Of the 1,400 adults that we surveyed, only 13 of them received a vaccine in the hospital in the last couple of years. So we looked at the opportunities that were missed to actually capture adults with chronic health conditions in the hospital setting, and at least 57% of our cohort missed an opportunity for pneumococcal, and just under 30% missed an opportunity to get flu vaccine. So we are missing key opportunities. Next slide, please. I'm going to skip this slide because I've run out of time. So really, we do have, unfortunately, suboptimal vaccine uptake amongst our adults. And I wish I had a rosier picture to tell you. You know, we have got great news stories and we do great programs when it comes to the over 65s, but we are still need work in other groups. And our coverage isn't comprehensive across all states and territories. So really, I think we need to be looking at more multifactorial efforts. We need to work with primary care, but we need to think beyond that setting too, around how to improve access to vaccine for adults with and without chronic health conditions. And we need to provide a lot more vaccine encounter support to those who don't traditionally deliver vaccines, so that they can be strong advocates, just in the way that our primary care colleagues have been for many years. So thank you.
And thank you very much, Holly. You've touched on some really important issues that, you know, IFA has been studying in our recent work about changing the conversation on adult vaccination. Some key words that really pop out to me is, you know, the value of registers that talk to one another, you know, the expansion of vaccinated gateways. And in doing that, we need the diabetologists and the cardiologists to actually also understand the power of the vaccine.
Yeah.
I also think that we've touched on here patterns of delivery, but also social determinants of health. You know, we've found that, you know, the public health messages assume the same level of health literacy across the population. They assume that. And I think there's some very critical lessons there. So, you know, I'd like to move quickly on to Kim Sampson, CEO of Immunisation Coalition, because one group that we haven't talked a lot about is civil society. And I really think that we are a legitimate player in this big movement. So Kim, the floor is yours.
Thank you very much. Okay. Excellent. Thank you, everyone. And Holly did touch on a lot of the government programs that are going on, and some of the activities that her group has been able to undertake. And so I wanted to talk about who the Immunisation Coalition is and what we do. Let's see if I can change the slide. No, I can't. So next slide, please. Okay, so the vision of our group is that we will improve the protection of all Australians against infectious diseases by advocating for immunisation. And the mission has three components: to create public awareness regarding the importance of immunisation. And we do that through providing materials and communication programs. We cooperate with the key Australian professional bodies, consumer advocacy groups, and state and territory governments in their educational activities. We also work with consumers, health professionals, and organisations with an interest in immunisation, ensuring that the information provided to consumers throughout our website and other communications channels is current, easily understood, and most importantly, scientifically informed. Next slide, please. So the Immunisation Coalition began as the influenza specialist group in the 1990s as a virtual organisation, although it did become incorporated in 2006. But importantly, in 2007, we commissioned a report into the cost of influenza to the Australian health system. While Australia's reporting system is comprehensive, much of the work to generate these numbers were done through modelling. Now, keep in mind too, this was back in 2007, so there's a lot of water that's gone under the bridge. But basically, what we were able to determine were that there were between 1,500 and 3,000 deaths in Australia. There were 18,000 hospitalisations. and over 300,000 GP consultations as a result of influenza. And Australia has a population currently of about 25 million. So back then, maybe 22 million, something like that. But next slide, please. So a short history, in the 1990s, the use of influenza vaccine in Australia was low at around 500,000 doses per year. And we had a population of over 65, around 1.9 million. The general public was very much unaware of the severity of influenza, and we noted that doctors were not recommending influenza vaccination, partly because they did not see it as being important and did not believe that the vaccine was effective. And of course, there was no promotion or advertising about influenza vaccine or vaccination at that time. So the ISG, or the Immunisation Coalition, then began holding media campaigns to raise awareness and to lobby government. Next slide, please. Holly actually has already talked about this, about the national program, and you can see that in 2020, this year, we had 18 million doses, which was distributed throughout the country, which represented about 70% of the population. Next slide, please. So the National Immunisation Program was set up by the Commonwealth and state and territory governments in 1997. Its aim was to increase national immunisation coverage, to reduce the number of cases of disease that were preventable through a vaccination program in Australia. In 1996, as you can see on that chart, we were providing about 2 million flu doses to anyone aged over 6 months of age. With the introduction of the National Immunisation Program for people over 65, we began to see an increase in the amount of influenza vaccine that was being distributed. And as you can see again from that chart, we were about 2 million around 1997. And by 2009, around the time of the pandemic, the NIP was expanded to include for at-risk people. One of the things that occurred was that in about 2006, the Influenza Specialist Group, as it was called then, and now the Immunisation Coalition, put together the report that I mentioned earlier and took it to government, arguing that people over age of 50 should all receive a free influenza vaccine. Of course, this was rejected by the government, and instead the government came back a couple of years later to introduce the at-risk groups, and so that included people that were medically at risk, pregnant women, and so on. And from that time on, again, we started to see a steady increase of vaccine uptake and manufacturers bringing more vaccine into the country. While all of this is going on, of course, the Immunisation Coalition was starting to ramp up its media activities, particularly from 2008 onwards. And you can see that steady increase of influenza vaccine being made available to the public. And we were not only seeing an expansion of the government-funded programs, but we were also seeing larger numbers of the general public opting to pay for their own vaccine. And then, of course, as time progressed, and I can see that the numbers at the bottom of those dates have moved out of sync for some reason, but what we did see again in 2020, that due to concerns about COVID infection with COVID-19, we saw a huge spike in influenza vaccine production and distribution in Australia. Next slide, please. So talk a little bit now about what we do. As a group, we run activities and events. We undertake media campaigns. We provide education to healthcare professionals and to consumers. We develop publications which consist of healthcare GP guides and other fact sheets. We have developed a variety of tools for healthcare professionals and decision aids for consumers, and we undertake consumer surveys to better understand the mood and thinking of the community. Next slide, please. So in terms of the activities and events, we, in terms of awareness, we run adult vaccination programs, and that includes things such as a program that was focusing on influenza and heart attacks. We undertook a program that specifically looked at vaccination and pregnancy, and of course, pneumococcal disease. We also undertake news briefings to generate interest so for example, recently, how the COVID-19 is impacting on Australia's flu season. And prior to that, we undertook one that looked at school-based immunisation programs. And what we did see was the HPV campaign proved to be very, very successful and had a high media impact. We also develop videos. We have our own YouTube channel, and we populate that regularly with new productions and circulate that throughout the consumers, but some of them are directed to healthcare professionals as well. Next slide, please. So this is a typical media launch. This one was a couple of years ago. So we used, in this particular case, traditional media. We managed to get onto the major television programs. We had significant radio pickup. So when we analyse these things, there are these kind of magical figures that come out. They talk about reach of over 24 million. Well, we had a population of around that, so I don't quite understand how these figures come about, but that's what we are told. We had very, very successful TV coverage, though, with all the interviews syndicated nationally, resulting in, again, a total reach of about 2.6 million. But I'll move on to the next slide, please. This is just highlighting about raising awareness of the risks associated with influenza during pregnancy. We were indicating through this program, and this is largely a social media campaign. We talked about the 3-in-1 benefits to the mother and infant, the fact that the mum is protected during pregnancy and through the early months of motherhood with influenza vaccine. The unborn baby is protected through the transplacental antibodies, and the young infant is protected through breast milk. And there are similar protections caused or made available to the mum through with pertussis vaccination. We worked with what are called the influencers. These are mummy bloggers and a variety of other social media tools were available to us. Next slide, please. This was the HPV school-based program. I won't talk any more about that. I've already covered that. So next slide, please. We undertake public vaccination clinics. We've referred to them as vaccination cafes because we actually made, we provided a free cup of coffee for everyone that was vaccinated so they could sit down during the observation period, the 15-minute observation period after the vaccination. We started doing this at Melbourne Town Hall in 2018, and we were able to get 1,200 people from the general public vaccinated. The vaccine was donated to us through a variety of sources. And so, as I say, 1,200 people were vaccinated. Now, in 2020, of course, this year, COVID-19 arrived. So we were still able to run the clinic there. We managed to vaccinate 500 people, but we did it in a very safe and effective way, observing all of the COVID-19 safety conditions, social distancing, etc. It ran like clockwork. It was a beautiful event, and we will continue to do those in 2021 because COVID will still be around and we may or may not have a vaccine. We also ran similar programs at the Melbourne University. We've been doing that for 10 years, and that is largely to university alumni and international students. Next slide, please. And these are just some of the images from the vaccination clinics. We vaccinated the Melbourne Lord Mayor on camera. Numerous representatives were giving interviews to both TV and radio. Next slide, please. This is the way we structured our floor plan during the COVID-19 Melbourne Town Hall clinic. You can see we've got the post-vaccination waiting areas, pre-vaccination waiting areas. We've got areas waiting to be registered. We had people lining up outside on the street. We had a large number of volunteers maintaining crowd control and ensuring that that social distancing was maintained at all time. Next slide, please. There's another clinic that took place in South Australia where we used underground car parks, and as you can see, there was one person per car park getting vaccinated, and we were targeting people over 65 for that particular clinic. Next slide, please. And I'm trying to race through this now because I know the time is ticking away. In terms of media, we have a very strong website usage. We use social media very effectively. We've got 600,000 Facebook users. Like everyone else now, we have to deal with the anti-vaxxers. We have about 100 anti-vax trolls at any time harassing us. We still use traditional media, and as I said before, we use influenza bloggers. Next slide, please. Again, just more images. Next slide, please. And that was about the adult vaccination campaign, using largely Facebook. Next slide, please. And these are just really images of some of the projects that we undertake that we're focusing on the medical profession. Next slide, please. Again, we utilised Instagram in one of our campaigns. That proved to be a successful mechanism. Next slide, please. And next slide, please. Education, very important. We undertake an annual scientific meeting each year. We undertake an adult immunisation forum each year, which covers those topics you can see there. We have webinars about once a month, once every 6 weeks, and we're about to introduce podcasts. Next slide, please. publications. We run a daily media bulletin that covers a whole range of relevant topics. We have fact sheets and guides for influenza, vaccination and pregnancy, pertussis, meningococcal disease, pneumococcal disease, shingles, and all funded vaccines. And we develop discussion papers on vaccination of healthcare workers, antiviral medications. Next slide, please. We run surveys, consumer surveys. We've been doing that since 2013. We also have questions for GPs. And we're getting come to the last slide. Next one, please. And we've developed decision aids to make it easier for immunisation professionals to vaccinate. Our PneumoSmart vaccination tool. Pneumococcal disease vaccination is incredibly complicated, and we've managed to develop an app that answers all the questions for the immuniser. We also develop other apps that act as decision aids for consumers. And look, that's the next slide, please, which is the final one, to say thank you very much for your time and apologise for going over time. Thanks, Jane.
Kim, I think that you did an excellent job in the time that you had. You know, one of the challenges with all of these webinars is that there is so much good practice going on, and it really is about how do we gather that together and see whether we can transfer it, we can replicate it, we can pull it apart. One of the ideas of having these webinars and gatherings is so that people actually know who they don't know. And I think that's equally important. You know, people in the North are certainly looking at programs in the South to see what worked and didn't work. I'm fascinated with the apps, so I'm going to come back to you and ask a little bit more about that, because one of the things that we've found at IFA is just the complexity of these vaccine schedules. They are very, very complex. And so I think the consumer is really on the back foot already in understanding, you know, the various vaccines, and so they have to trust, you know, people like Dr. Cassianos, you know, the trusted person, you know, or, you know, the pharmacist. So these trusted gateways. We're going to open it up to the floor now, but before I do so, I just want to acknowledge Securus. Our work in these 3 webinars is supported by an unrestricted grant from Securus, and we thank them for that support. So I'm going to call on Carolyn Grammer, and Carolyn has a question for the panel, and then I will come in. So Carolyn, are you able to unmute and come in to ask your question?
I sent it a while back, like just before, so I don't even remember what I asked.
All right. So what about
There's so much going on right now?
I can imagine, but you've certainly been very active. It really was a question about anti-vaxxers, and that's certainly, you know, one of the barriers. So I just put the question, you know, to Dr. Cassianos. You know, to what degree does the anti-vax movement in the United Kingdom impact uptake rates? So let's start with you, sir.
Well, as you know, we have the king of the anti-vaxxers here in the UK. Wakefield was found to be a crook, and the title of Doctor of Medicine was removed from him by the General Medical Council. Unfortunately, he emigrated to the United States, where he's doing a lot of harm there. For about 10 years, at the beginning of this century, we had a lot of problems with the anti-vaccination movement because of Wakefield. But slowly, patients actually we got their confidence back. Then we saw a movement coming from Europe from 2010 onwards, emigrating to the United Kingdom. And again, we had a lot of anti-vaccination campaigners. What we did, we actually brought them in, tried to educate them, educate the parents, the families about vaccination, their neighbors, talk to them and so on. So slowly, really, they went into hesitancy. And now we really don't have an appreciable problem. There is a problem, there is no question about it. It's more of a hesitancy which sometimes is from what they see in the media. Because when we looked in 2018, what do they see in the media? More than half of what they saw was anti-vaccination rather than pro-vaccination. So yes, we do have a problem, but in primary care, we're working with parents, with patients, education, and we do not enter into debates with anti-vaxxers. We leave them alone, and I never enter into any debate. And I think we are actually winning because our vaccination rates for children's immunizations for adults are actually very high, and we're quite happy with that.
Good. I'm going to ask Megan Acton to come forward and ask her question. Megan?
Hi, Jane. I don't think that was my question, but I can read it out loud.
Okay, good.
So the question was, one of our challenges in Canada is the sharing of information between different healthcare providers. Are Australian pharmacies, physicians, and hospitals easily able to share information on who has been vaccinated and when?
Okay, Kim. So is there a sharing of information about who's been vaccinated and not? You know, is there a central registration system?
Yeah, I just posted that into the chat space, Jane. But our Australian Immunisation Register now has been extended to capture adult vaccination. So that occurred in 2016, which was a big move for us here in Australia to have that extension. However, you know, it really hasn't been a huge shift in terms of getting good, accurate data from it, and it will take time. One of the challenges is that, you know, not everyone has access to it. So you need to actually be granted access to the immunisation register. And I know that, you know, across primary, tertiary and pharmacy, you know, there is still variations in who can access it and how regularly they're doing it. And also the challenge is that, you know, adult vaccination occurs in other settings, community settings that Kim alluded to, workplaces, you know, and none of that coverage is captured in our register. So we've still got a lot of problems there.
Yeah, and similarly in Canada and in many countries of the world, you know, we know that Italy has registers in every region and they don't talk to one another. So, you know, it's an area that we need to focus on. One last question to Kim, and then I'm going to ask each of the panelists to give us one takeaway message. So if you can just think about that, and I'll start with Dr. Cassianos. So Kim, I'm interested in the education programs. You know, clearly the Immunisation Coalition has a strength in that area. You know, are there different education programs, you know, that sit within pharmacies, that sit within the government, that sit in, do you ever sort of come together around the impact of these messages?
Well, it's a good question, and I think Holly talked about the different state activities, because while the federal government does provide funding for the vaccine, the management of the vaccine occurs at a state level, and each state has its own messaging, even though the federal government also has its own messaging to GPs, for example. So about 2 years ago, we held a roundtable meeting where we tried to get GPs, pharmacists, state and federal government together to talk about the issues around messaging, because what we see each year is different opinions on the timing, optimum timing of the vaccine, different messages about which vaccine should be used, and generally it ends in confusion for everyone. Not only that, we're now seeing different vaccines, if we talk about influenza, a variety of vaccines that are now available, and in 2021 we're going to see a cell-based influenza vaccine enter the market. So, you know, 10 years ago it was very simple. We had a trivalent influenza vaccine. Now we have about a half a dozen different variations. What we're trying to do, and we actually wrote to the government only about 3 or 4 weeks ago, requesting the opportunity to talk to them about having a unified message right across the country. But you know, working with governments is sometimes very, very difficult, and particularly when they have what they consider to be bigger issues on their plate. So we've got a long way to go, but it is a serious issue, I think.
And it's, you know, I really respond warmly to your answer, and I would like to say to the government, what bigger issue is the health of your nation? But, and also, you know, and that's the kind of response that we need to be ready for. But I just go back to our first presentation, Dr. Cassianos, you know, who actually talked about the incentives, you know, that that health professionals receive from the vaccination and the slight competition that goes on. What this session has shown me is that we truly do need to be sitting at a table, cross-sectoral and cross-discipline, actually presenting the good ideas and good practices, because each of our speakers today has clearly presented good practice. What I didn't quite understand until now, Kim, is that, you know, management happens at a state level in Australia. And while it's funded at a federal level, the management is at a state level. And I think that does give us some insight into what is possible in Canada. Yes, I know that funded, you know, the funding, you know, happens at a provincial, etc. But, you know, I think perhaps we need to start using different language when we're talking about, you know, the potential of a harmonised program in Canada. So I want to thank each of the presenters today. And just to put this in context, you know, Holly and Kim, it's very early in the morning on the east coast of Australia. And for Dr. Cassianos, it's quite late in the evening in the United Kingdom. And for us, it's the end of the day. So, and for people across Canada and internationally, we thank you for being on this webinar. We're here because we're in the midst of a pandemic. And every single time I'm on a Zoom call, I'm very conscious that, you know, tens of millions of people have been diagnosed with COVID, and 1.6, 1.7, I didn't look at the numbers today, but many people have lost their lives, and many family and friends and kin have lost someone, you know, to COVID. So we need to come back to the reality and see that this is, you know, an issue that we need to come together on to create solutions. So Dr. Cassianos, what is your takeaway message to the attendees on the call today?
Well, my message is engage your patient, engage the parents. Whether it's the shingles vaccine or the pneumococcal vaccine or the influenza vaccine or the children's vaccine, we need to engage with our patients. As regards to the influenza vaccine, because of COVID, because of the problems we have, the message we send to our patients today and every day since the beginning of September is that we have reserved a vaccine for you, a flu vaccine for you. It's here waiting for you. And that has actually brought a lot of patients to us to get vaccinated because they feel that it's theirs, there to take. And of course, in the media, you hear a lot about shortage of vaccine, and they know that we have reserved a vaccine for them. Engage the patient.
Yeah, what a terrific message. You know, we've reserved a vaccine for you. It's here waiting for you. Come and get it. What a terrific message. Thank you for that. That's going to be tweeted out tomorrow, I'm sure, George. All right. Holly, and I want to acknowledge your two lads. I don't hear any banging at the doors yet.
I just realised I wasn't on mute then too, so that was lucky because it's been ongoing the whole time. These banging of the door. So
how old are they, Holly?
I've got a 3 and a 5-year-old, so it's still quite young in my space, but
they've done very well. So over to you.
They are very good at these Zoom meetings now. But look, yeah, just to echo this, we are about to enter a space that, for many countries, we have never delivered an adult vaccine program to the level that we're going to need to deliver it next year if that COVID vaccine comes through. And that is, to a space now that we need to start looking at, what are going to be the access strategies that are going to help, but what are also going to be the social and behavioural drivers to promote this new vaccine, drawing on what we know about adult vaccination for pneumococcal, influenza, and so forth. Also drawing on some of our vaccine programs in the travel space, because we do that really well when it comes to adults. And so, there are lessons to be learned. But, I think at the moment it's, that there is this little bit of a challenge to actually thinking about, well, our normal strategies are not going to be enough. What else is going to be needed? And getting the voices of everybody into a room. And what you said about intersectorial is crucial right now. And, someone, wrote out recently about the fact that we could be currently learning about how to deliver adult vaccine programs by looking at strategies such as cancer screening, looking at bowel cancer screening, breast cancer screening, programs that have been running for a long time in an adult space, and have got huge reach in the way that maybe our adult vaccines haven't yet. And so that is truly then the intersectorial opportunities that we need to take on.
And through the lens of ageism.
Yep.
We haven't touched on this, but the value of a life is going to be critical in the conversation of who gets a vaccine. Yep. And so we actually have to put the elephant in the room to say, okay, because I know that many older people around the world are also feeling, well, am I worthy or am I not? Or if there's a vaccine, should it go to someone else before it goes to me? These are really ethical questions we need to struggle with right now. So, Kim, over to you for your final message.
Yeah, sure. Just picking up on something George mentioned earlier, and also what Holly was referring to, and it in part touches on the anti-vaccination movement. Look, it's really important to be pushing out positive messages about immunisation, positive stories. We've seen, how the introduction of vaccines has really changed the landscape. If you think about smallpox and polio and all those kinds of diseases that have almost been or have been eradicated in some cases. So what we know that there's a lot of skepticism now about a COVID-19 vaccine. And that's been partly exacerbated by stories that are coming out through anti-vaccination groups, but there's a whole reason for that skepticism now. It's so important that we get the positive messages out there, and I agree with George. You don't take the anti-vaxxers on. You just put the scientifically informed information out into the public arena and encourage people to go to look at it.
Thank you very much, Kim. We have heard three champions today, and clearly that there is a connection through what they're saying. Messages must be positive. Engage patients and parents. There's a vaccine reserved for you. It's waiting for you. Come and get it. But it's also about the equity issues and also the targeted populations of those most vulnerable. And by that, I don't mean that they're not healthy, but they're vulnerable to the serious complications of vaccine preventable diseases. So we've got to put that in that context. So messages are important. And also we've got to actually create the message and the opportunity to expand our vaccine gateways beyond the trusted professional in their GP practice, but look at innovation, and perhaps it's in hospital, perhaps it's in mobile travel clinics, and perhaps it's about looking at, who is the portal through which we actually have to walk. Please join with me in thanking our champion and our speakers today. and the opportunity to be with you at some time in the day. I want to also acknowledge Laura Tamlin-Watts, who just made a poignant comment that we need to finish on. And that is, around the world today, there is a general acceptance that the death of an older person is okay. That's not the case. And so if we're very fortunate, we can actually move into older age in a healthy way. And that's why we are doing these webinars, to actually help to build the capacity of others. So we thank all of the speakers, Andra, for your leadership in bringing this together. And also thank you once again to Securus for their unrestricted educational grant. So stay safe and stay well, and thank you all for being with us today. All the best.
Thank you. Bye-bye.